Good morning, everyone. Call this meeting of the Assembly's Health Policy Committee to order. It's April 7th, 2021. I'm Meg Zalatel, and I co-chair this committee with Assemblymember LaFrance. Ms. Leppy, could you please call the roll?
Yes. Ms. LaFrance?
Here.
Ms. Zalatel?
Here.
Ms. Allard? Mr. Constant? Mr. Dunbar? Mr. Rivera?
Present.
Thank you.
Okay, thank you. So today on the agenda, we have two items. The first is a Anchorage Health Department update, and this is going to be a very truncated update, about 5 minutes before we turn to the COVID-19 transition plan, which is really the main topic on our agenda. I've asked Director Harris to highlight any issues we may need to be aware of or want to follow up on in her update, and I appreciate her flexibility in doing this truncated update. With that, it looks like we've been joined by Member Dunbar as well. And then Director Harris, if you'd like to go ahead and take it away.
Absolutely. Thank you for the opportunity. Yes, so I'll run through this relatively quickly. As we are just doing a lot within the department, as you all know. Within our fiscal area, we've been focusing a lot on a COVID-19 community funding grant for $14 million. These funds are passed through from the state and will help support COVID testing and vaccinations with an emphasis on health equity. So excited to see some partnership in the community around that and getting those funds into our community as well over the course of the next several weeks. We continue to work with the state of Alaska on the $10 million ELC contact tracing grant. As you know, they were involved in supportive around contact tracing, but recognizing that our contact tracing staffing has been plentiful at this point. They have also been able to start assisting on vaccine-related educational activities, and we really encourage the use of that resource. AmTrace is able to provide a telephone line to be able to answer questions around vaccine hesitancy. That number is 531-5100. So a really great resource for our community to get information out about vaccines. As we look at animal care and control, just want to highlight the next board meeting is going to be coming up. Oh gosh, I'm sorry, I have March's meeting date, not April's. There's just a lot of conversation right now happening in animal care and control around the leash laws, and so that may be of interest. Animal care and control continues to do a great job reuniting animals with their owners. 96 animals through February were reunited and 236 were adopted through February. As we look at childcare licensing, we got to celebrate Childcare Licensing Day on February 26th when the governor had a proclamation around that and just celebrating the great work that many of our childcare licensing facilities have been undergoing. They continue to be challenged at times with COVID and cases amongst children in the childcare facilities, and our team is working to help with mitigation strategies, but also help to support when COVID positive cases are identified. Our CSD Community Safety and Development team has been working on the ESG and CDBG funds as our regular funds and also our CV funds, and you'll be seeing that on the Assembly agenda over the course of the next several weeks as well. We'll have on the April 13th agenda is the public hearing for the 2020 action plan regarding HUD as well. So a lot of work happening in our CSD division right now, and want to highlight James Bowman, a staff with 35 years of institutional knowledge, retired at the end of March as well. So a lot of shifting in that team in connection with our housing and homelessness services as well. Our 4 of 5 staff for that work group have been hired and been onboarded and are learning about ESG funds and HUD regulations and and really getting connected to the CSD team so that they can provide great program support to those funds going forward. As we look at senior and emergency outreach, I want to highlight that one of our service coordinators at the Chugach View Manor continues to deliver over 100 meals each day to residents in partnership with the United Way program, and just a really great stories and impact for our community there. As we look at our Division of Public Health, our environmental health service team continues to provide great support to the administration as we look at regulations and recommendations within the community for safe practices around COVID, and helping to approve plans as businesses are looking at making plans for the future as well, and making sure that those are COVID safe. Our WIC program saw February was the 6th month of increasing participation in Anchorage, which was a great success. We were seeing a declining in participation, but now we're on the 6th month of increase. So looking forward to that continued upward trend. Our SNAP outreach program, in partnership with the Alaska Food Coalition and Food Bank, was able to do and engage in 2 educational sessions with legislators about food security during the pandemic. And our community health nursing team continues to really seek out our positions for our supervisors and struggles in that area to find those great fits for the department. So if you know any great nursing supervisors, send them our way. Otherwise, our non-supervisory vacancies are now closed, which is great, and we're getting staffed in that area. We've also started to see a shift in our community health nursing team move from what we were doing in the early stages of the vaccine rollout, maybe at the Blood Bank of Alaska Vaccine Pod, and starting to shift into more community outreach efforts. For example, we were able to do a 2-dose outreach clinic with some of the Pacific Islander communities, and we continue to plan to expand more in March and April in those opportunities. We continue to have our boards and commission meetings, and I encourage people to take a look at that schedule and participate as desired. Thank you.
Great. Thank you, Director Harris, for the quick update. Our congratulations and thank you to Mr. Bowman for his service to the Health Department, and just underscoring that vaccine phone line at 531-5100. That's the correct number, right, Director Harris?
That is.
Oh,
thank you.
Okay, great. Thank you so much. So we're going to turn on to the main topic for today's meeting, which is the COVID-19 transition plan. We have Incident Commander, or EOC, Emergency Operations Center Incident Commander Bob Dole with us today and his team. As we go through this presentation, members, please put yourself in the queue as questions come up through the presentation. We're going to try to do them on a slide by slide or topic by topic basis, as long as we can continue to move through the presentation. And if you can't get yourself in the queue, you can go ahead and send me a text message or an email, and I'll make sure that your questions get into the queue. With that, Mr. Dole, you are free to proceed when you're ready.
Good morning. This is Incident Commander Bob Dole. I'd like to confirm you can hear me and also see us the first slide, the title slide. Is that working?
Yes, on both accounts.
Okay, good morning. So I'm Incident Commander Bob Dole. Speaking with me today will be the Mass Care Branch Chief, Kojin Transberg, and Dr. David Parker. As we're going through these slides, our job and duty to you is to avoid acronyms. Since 9/11, it's become clear we need to speak in plain language. There's a few acronyms we can't stop ourselves from using. I'd invite you to call us out on any others. Because we're not in front of you in person, we will settle up afterwards to fill the jar for and provide that to an appropriate entity. How we got here today. There's a normal cycle of things that happen. We're not going to go through this in detail, but if we look at the disaster response at 12 o'clock on there is pretty much business as normal, if you will, how things are going along. in the different departments handling roles and missions. Office of Emergency Management is doing things to be prepared and the municipality prepared for something to happen. At the 1 o'clock where you see purple, that's something happened. In this case, it was the COVID pandemic striking us as well as the rest of the world. As we start working our way through the rest of that clock, if you will, that has to deal with how we prosecute or address the mission. When that purple event occurs, it's an event of such complexity that existing organic departments and offices within the municipality cannot handle the response. That's when you stand up the Emergency Operations Center. That complexity is looked at from the different entities that need to be brought together to address the response, and also, frankly, in this case, if we look at the 164 residents who passed away directly attributed to COVID and the extensive suffering, but it is complexity that causes the EOC to activate, and as we get out of complexity, even though there's still a lot of work to be done, that brings us back around that clock as we go to that 9 or 10 o'clock position where we implement the transition plan. With where we are today, it's taken us over a year to get here. We're at that point where we're talking about that transition plan. Once that transition plan happens, we recognize that there's still work to be done, but the departments and offices with the initial roles can pick those roles up again in going forward. It's kind of, if you think of a wildland fire, afterwards there's still hot spots to be cleaned up, but you don't have the whole incident apparatus to get there. We're rapidly approaching that point, and part of my job as an incident commander is to plan on how we do that effectively. As I touched upon, it was a route to get here. We didn't do this overnight where we got to this point. The EOC activated over 13 months ago, a state of disaster, and the feds had their disaster declarations after that, even though their emergency operations centers also stood up in that time frame. Going forward from there, we continued to build and kind of increase the operations tempo of things that were happening. And then we've kind of, in terms of long-term looking out, we know the state fell out of its emergency declaration. It ended February 14th, and I know you all are having discussions about that as we're going forward, what that looks like for Anchorage as well going forward. The Anchorage Emergency Operations Center is always there. It stands up with an incident management team when the complexity warrants it. It goes back into a standby role and a coordination role as necessary outside of that time frame. A big question that I'm sure is on all your minds, and is on ours, who's going to pay for all this in this disaster going forward? The basis of how we're prosecuting the response to the disaster, the primary funding mechanism is Federal Emergency Management Agency, or FEMA, public assistance grants. Basically, public assistance grants are authorized when there's a federal disaster declaration going forward. And then they look under the Stafford Act on how we actually go about utilizing those funds. And just a quick aside, I can't see the chat, so somebody please speak up when you have questions because I'm presenting. So we can see the funds were authorized there, and those are the funds we rely on as we go forward to provide the response for the citizens of Anchorage. The rules on the funding, it has to be necessary and reasonable to the response. We can't be using it for things other than that are options, but we have to show that it's it has to be done to respond. And kind of one of the key things that was great that happened out there for us as a municipality, the president's memorandum on January 20th waived the 25% local match until September 30th for this sort of public assistance. What that means to us today is that neither the local jurisdiction nor the state have to pay through September 30th the 25% of the cost of the disaster response. Normally in Alaska, the state pays the local match. They have historically since statehood. However, for a disaster of this size, that would be a significant hit on the state budget that we rely on for so many other services as well. There's some confusion with that. I wanted to touch upon briefly with the memorandum. it waived the 25% match until September 30th. It did not say that the federal disaster declaration is ending, so we can't get reimbursement beyond that point. It did not say that there is a known end to when the disaster will be ending. All it said was the 100% federal reimbursement ends on that date. They can extend it at any time. The state has also communicated to us that after that date, it's the state's intent to continue paying the 25% local match through the duration of the federal disaster declaration. They also have to do that for their agreement with the Federal Emergency Management Agency, but was reassuring that they confirmed when we go beyond September 30th, if the feds aren't paying 100%, they will step in. And you can't use federal funding where there's already another funding, federal public assistance funding through FEMA, where there's already another source in place. For instance, your incident commander, myself, is paid with 101 funds, and as you all budgeted for that. And we can't pay my salary with FEMA funding because, as an example of, because there's local funds available for that. Director Harris and other folks who are just part and parcel spending most of their time on the response also are in the same position. Where we've had state distributed grants for other purposes, we can't divert those or can't not spend those on there and use federal public assistance instead. And what we are doing is those funds have to be used first as they were intended. If there's supplemental needs in those areas, then you can look to FEMA public assistance. And also where we get other federal funds, I think HUD CDBG and HUD ESG, which I know are acronyms, but for this committee, I think they're appropriate. Our funds also, you have to demonstrate that you are not diverting those funds from where you would have otherwise spent them and using FEMA public assistance funds instead. So we, sorry, went the wrong way here. So that's how we're paying for this. And this is the Emergency Operations Center structure we stood up to address this structure now. This exists outside of the health department or other entities. It is an ad hoc organization. It grows and shrinks or changes people around to meet the needs at any given time. The structure is etched in chalk and frankly probably changes some level of who's where or who's no longer there about every 2 weeks. This is our current snapshot in time. When certain areas need more work effort, we plus up people. When an area is no longer needed or is not as complex, we take them down. And that we have taken down some areas already. These are areas that we just demobilized without having to do a transition as we're talking about today. Areas we didn't have the medical surge that was going to require municipal participation to fully activate the Alaska Airlines Center to provide care. We didn't have a mass fatality event that we had to figure out where to place excess remains that could not be accommodated within the existing feeding system. The food bank and other non-governmental organizations have stepped up to address mass feeding that did not require our participation in it. Those functions are still ongoing, but they weren't of a level of complexity warranting the Emergency Operations Center to continue involvement. So there are some functions, if you look back here, that we did not transition out. Those are the things we're doing today of operations that we see transitioning over to the health department. Medical countermeasures is the vaccine program run by the municipality. That I'll touch upon in greater detail shortly. Mass care is the sheltering we provide for those who cannot obtain but need shelter on their own. And public health is testing. Most commonly you see that as the visit testing sites across the jurisdiction and the site visits we do. To transition those, there's a process here. And we'll have a text version after this if this one's a little daunting of how we go about doing it in an orderly fashion. What's important when you transition is you do not lose momentum in addressing and mitigating the disaster that you stood up the EOC, the Emergency Operations Center, for in the first place. So the transition process P starts in that lower left-hand corner in the gray, the prepare transition plan. After that, there's a recognition between the incident management team and the departments of the Municipality of Anchorage that we need to talk about what this transitions look like, how we're going to do it. And then there's a series of steps we go through there to make sure that as we're going forward, it is thoughtful, it's deliberate, it does not result in a break in providing the services necessary to keep going forward. That will be what results in the transition from the Emergency Operations Center to basically the Anchorage Health Department running vaccinations that we're currently doing, as well as COVID testing and mass care functions. Office of Emergency Management will shift to taking a coordinating or supporting role, doing the things to make that mission and the rest of municipality successful in addressing the disaster. A transition from an Emergency Operations Center incident management team back to the existing departments is a event that happens hundreds of times per year. Every time there's a big wildland fire or other things we read about, this happens. This one is a little unprecedented for us as well as most jurisdictions, however, because of the duration, the complexity, and also some of these functions just weren't clearly aligned within the health department beforehand. I think the division between the mayor's office and health department on the homeless services area is an excellent example of that. So to go forward, if we think back to that P, step one is in coordination between the Emergency Operations Center and the receiving organizations, Office of Emergency Management, and Anchorage Health Department. We explain what we're doing it now, who we're doing it with, what's available to transfer, who and what equipment or other resources can transfer with when that is picked up. We stand down the EOC from the control role, and these other organizations stand up to pick it up. When they look at that, they look at the staffing they have, they look at the contracts we can bring over, the staff we can bring over, the other resources we may have. We've borrowed some vehicles from across the municipality for the EOC teams. Whatever is involved there, they look at that to determine what they see the mission ongoing as, what resources we can flow over to them, and what additional needs or changes they may need to make this work. And as that will happen, Office of Emergency Management will pick up the support role, while Anchorage Health Department picks up those three operational areas. So we have gone through, developed a transition process plan between the entities, and we have started executing that with just meetings. First, there's a written description of who's doing what now, but really helps to sit down at the frontline level. Who's doing the work now? Who will be doing the work in the future? To figure out what that needs to look like for the receiving organizations. You can see there the list of what meetings have been done. We have a couple more meetings at least to be done in the future as those discussions are had. And those are probably most important to understand what's really involved in those functions, what's really involved in coordinating a new venue for doing vaccines, or the contracts involved in mass care. Taking that information is then the receiving organizations have the grunt work ahead of them in terms of determining what they need to keep going forward, to keep moving forward in those areas, and also how to organize them for their organization. They'll make sure that it's going to work for them in terms of span and control and doing what they need to direct it. They have what they need to do it. They have options to lateral contractor staffing, funding other contractors from the EOC, but they may have other roles or requirements that also need to be addressed to work in their department. As we sort out those things, and I might add for that prior step, that is a whole of government. It isn't just up to those departments. They need some support from, as necessary, Office of Management Budget, Human Relations, the Muni Attorney's Office. As we sort that stuff out, and get that sorted out. That's at the point we release operational authority and OE, Office of Emergency Management / the residual EOC goes into a support role. This is the existing structure we have for the Anchorage Health Department now. It is into this that they need to figure out where it makes sense for them to align COVID testing, COVID vaccinations, and the mass care operation. You can see in public health, they have at this point, they do some testing for other diseases and vaccinations. In human services, they do housing and homeless services, but they're not doing anything on par the scope of what needs to go forward here, and they need to figure out where it makes sense and where it works for them. Given the ongoing execution requirements, it makes sense. Office of Emergency Management has a proposed transitional organization as they understand the requirements at this point. When you look at this, you'll see after some of those positions a C+. That is not a grade on what the people currently in those positions would receive. Rather, that shows they're required for COVID response. Even after we transition these positions or these responsibilities into the Anchorage Health Department and the Office of Emergency Management, they can continue to receive federal FEMA public assistance to pay for the contractors or workers dedicated to those functions. Notice I said dedicated to those functions. They cannot do anything else. The OEM, the Office of Emergency Management Director, clearly delineates this on here to indicate these folks can't touch anything else but what is related to COVID response. When we run out of, when we determine these positions are no longer needed, or when the federal disaster declaration and any follow-on period, which typically is 6 months after the declaration ends, where you continue to spend in this area, ends, these positions are not funded and go away, as would the ones in the Anchorage Health Department once the disaster is ended, unless the Assembly and the administration opt to do something else. So let's look at where we are in the yes?
Before you go on, I actually put myself into queue. Could you talk just a little bit more? I think you touched on it almost there at the end. If these need to be dedicated positions to be FEMA funded, could you talk a little bit more about how that relates to the health department transitional structure and what things it may pick up and what may or may not be FEMA reimbursable?
So yes, Chair. So for the events or the areas we're talking about, positions dedicated to doing vaccinations testing and operating the mass care system, as we'll talk about in greater detail in a little bit, as long as they're dedicated to that, they're 100% funded, either as employees or as contractors. So what for the health department, they have to determine where it makes most sense to align them, and given they have a lot of folks working a lot of ludicrous hours now, they don't want to burn out those folks, and then the money will flow to support them, just like they will in the residual Office of Emergency Management. As long as they're doing 100% COVID 100% disaster response and they're identified as such, they are federal public assistance reimbursable. If after the end of the federal disaster declaration there's determined to be a residual need for increased capacity, at that point there has to be a discussion of 101 funding or another funding source for them for a long-term, for just perpetuity or however long that is. There may be other funds you all look to with Rescue America funds, which will be beyond the federal disaster, but won't be in perpetuity like 101 funds too. Did that address your question?
Yes, thank you.
So looking where we are in the branches to transition, we follow closely the daily testing trends of the vaccine, of the testing requested from the visit test sites previously Fairweather, but now just Visit as our remaining contractor. And we've pretty much hit a steady state, I think, somewhere between 180 and 200 since that real surge we had at the end of last year. Since then, I think one of the key takeaways is a lot of the things in testing have been first operationalized or normalized. We have the 5 drive-through sites around the town. I go through random ones about once a week. It generally takes me about 21 hours, sometimes 23 hours to get my results back from those. This is a long cry from the start when you would wait 6 or 7 days for a test result from any testing entity, and it fell into the why bother category. We have also built into the process there's some spots, particularly congregate settings, that are higher risk. So we have just built in the visiting teams to hit those as pretty much a set schedule. If you're at one of the municipality mass care facilities, you can expect somebody to show up with a swab to stick up your nose weekly. We also have a strike team capability. If we're contacted by someone such as Assemblymember Constant did last month with a concern about a given place having concerns, we can send them typically the next day to go do a mass testing event. Those are built into what your emergency operations center is doing for you now in order to keep us going forward with the response. One of the great things that has happened also with the school staying open, they have brought tremendous capability online. From the capstone trailers they have in 5 of their parking lots to the 22, they say now machines, really it's about 15 or 20 minutes, but with the school staying open, fortunately they took a conservative approach, but with the testing they brought online, it's really been great in terms of the added capability in the community. So this function, it continues, we continue to watch the numbers and try to figure out where we can increase testing access, but seems to be premature. I think the area drawing the most interest right now in many ways is vaccines. And this slide here reflects several things we look at. The municipality does not administer all vaccines inside the jurisdiction. It does, however, operate a couple of the mass sites. The Dempsey Anderson parking lot is one. The Forever 21 old store in the Diamond Mall is another one. We have mobile vaccination teams go out to about 12 sites on any given week for smaller groups that otherwise would have trouble getting access to shots. The congregate shelters are a recurring group on that list. We also do about 50 homebound visits a week of those who are homebound but need access to the vaccine. It's a challenge for them. Besides us going out there and doing that, you have all the private providers in town who are also making shots available. Many retail pharmacies are too. That blue line at the bottom reflects the where we are at the collective efforts going forward. Looking at the website this morning, in probably 110 days or so, we've vaccinated. Yes.
Please go ahead.
Okay, so since December 15th, we show about 104,000 that have been vaccinated on with either State of Alaska or Indian Health Service allocations. We do not get full access to the Department of Defense and VA information about vaccines. We have learned anecdotally or incompletely that probably over 2,000 vets have received VA allocated shots, and probably about another 4,000 to 6,000 have received the Department of Defense allocated shots inside the municipality of Anchorage boundaries. So we're sitting at about 110,000. We can document today about 104,000 have been vaccinated. That is tremendous news and shows the incredible efforts of the community going forward. We have done our part to contribute to that. Anchorage Health Department has been all over the allocation process to get those shots where they're best able to be executed, and finding innovative ways to reach other groups as well. But we have, just as that blue reflects the effort, the logistics to get that juice into arms, we got challenges ahead of us too. The first one is what we call vaccine hesitancy and access. We had an Ivan Moore survey done. We collaborated with Conquer COVID on that to keep our costs down and also get a state baseline on it. And based on that, when we get up around 60% of the 16 plus population, we anticipate we have a lot more barriers we need to overcome to keep getting more shots in arms. Even going beyond that, in order to get the necessary herd immunity to truly keep the schools open, to get our businesses back and open and thriving, we need, to talk to Dr. Johnston and AHD about 80% of the 16 plus population. Now, the reason 80% is higher, you see in other places, is we can't vaccinate those under 16 yet. There's not an approved vaccine for them. So you have to over-index in the 16 plus to offset that you can't yet vaccinate in the under 16s. We have a total population of 226,400, ideally of 16 plus. Ideally, we reach at least 181. But we know about 135, we got to find a way to raise that red bar up to where you see the gold or yellow or orange line, or we're not going to get where we need to go to continue on the path of recovery. The way we do that, overcoming vaccine and hesitancy, is first we recognize it's out there. We do those surveys, we look at national information, we talk with key influencers across the municipality to find out what the issues are that they're facing. And then we take that on. You can see there 41% of our current population have indicated they don't, who have not been vaccinated, say they don't want it. That's a challenge for us that we need to overcome. The way we overcome that is through the efforts of our public information officers or our communications teams. Just like the folks doing the vaccinations within the operations branch and those doing vaccinations over in Anchorage Health Department are growing that green or that blue bar graph on the bottom to get more shots in arms. The job of the key operational aspect of public information officers in this disaster is to raise that bar in terms of getting it up higher where it needs to be done. We're doing some things to increase access, such as we'll be bringing on the Northway Mall for a no appointment drive-in site. We'll also offer appointments, but no appointments starting probably the 14th or 15th. We'll continue the sites in the homebounds. Not this week, but next, we will be doing shots in 3 union halls in order to focus on unemployed in the trades and hopefully avoid the disruptions we had on the construction sites last year. But we're also, this group, we have bilingual staff in our public information office. We're translating materials into Tagalog, Spanish, Hmong, Samoan, Korean to reach everyone we possibly can. We're coordinating with our ads to figure out who we need to reach. We're really leaning on key community influencers to get where we need to get to raise that bar. So if you think back a slide, it's really kind of an interesting dynamic situation. We have the vaccination teams in medical countermeasures doing everything they can to get as many shots in arms and grow that blue bar graph up to the gold line. And we have the public information officers doing everything they can to get that red line out of the way so they can reach that desired level going forward. At this point, I'm going to hand over, if there are no further questions of me, and first I'd ask if there are any on what I've covered up to this point, otherwise we'll change speakers.
I do not see any questions in the queue, so please go ahead.
Okay, at this point I'm going to introduce Kojan Transberg to you all. He is our mass care branch leader. He's one of the 3 folks that came to us from the UAA MBA program and has been invaluable in our leadership roles. Cogent brings to this past experience running the UAA program for students with housing and food security challenges. He brings some phenomenal analytical skills to it and an unbridled passion for this area of challenge. So Cogent will be addressing your questions in this area now. Go ahead, Cogent.
Bob, thank you so much. Really excited to be here presenting this section to this body. The next 8 slides that I'll be speaking on, the goal here is just to identify some key players, roles, function, history of the response, all the important inputs that have really informed our transition plan, specifically around mass care, at which point I'll be passing it to my colleague, Dr. Parker. So just to kick us off.
Sorry, I'm sorry to interrupt. Could you speak up a little bit, or if you're using a headset or a microphone, just make sure it's a little bit closer to your mouth. You're a little bit quiet.
I'm so sorry, of course, yeah. Thank you, Chair. Can you hear me now?
Yes, it's still a little bit quiet, but just speak up, and if we can't hear you, we'll stop you.
Perfect. Yeah, will do. So for the next 8 slides, the focus is really on just helping identify some key players, roles, function, history of the overall response, really with the focus on being able to identify what are the important inputs that have informed the EOC's role in shaping a transition plan, specifically around mass care. So just to start that conversation, I think it's really important to define what is mass care within an EOC function. The important takeaway here is mass care is a temporary solution to address an immediate need. It is a temporary solution to address an immediate need. Our focus is ensuring that the folks that we care for are safe, secure, sanitary. We stabilize the disaster with the focus on providing that space for pre-disaster functions to get up to speed and carry on the work that we provide in the EOC absence. Bob, next slide, please. So how is that different than the continuum of care? The continuum of care is the housing and supportive services solution to address homelessness on an ongoing basis. Everyone I'm sure here in this body is very familiar with the Anchorage Coalition and Homelessness and their role. Very similar to how the EOC is a coordination entity for the COVID response, ACEH provides that coordination and really addressing long-term, what is the strategy around how we support people experiencing homelessness? And they do it through this vehicle, the continuum of care. And it's through that all the data collection happens, all the coordination of operations, and then most importantly, making sure that there's a network with the other PEH providers within the community to provide that true safety net around this larger concern of homelessness and supporting the needs of those experiencing homelessness. Next slide, please. We use this slide just to illustrate what is a traditional emergency mass care operation. Great example is if there was an earthquake or a fire, there's the incident. When the incident occurs, we see a huge spike in need. And then through targeted interventions, through the efforts of the individuals affected by the emergency, you see a gradual drop in the need for resources. Please note here, the average length of any kind of congregate shelter that's used in this capacity, it varies in terms of how long it's available for, but typically it's a range of anywhere from a few days to several weeks, which is very clearly the opposite of what we're experiencing today, being now over a year in this response. Next slide, please. What we do next here is just try to illustrate who are the key players in this response. What you see here is a map of the individuals that are a part of the continuum of care that were the shelter providers within the community. And as you can see here, the cornerstone is Anchorage Coalition and Homelessness as that coordinating entity. Next slide, please. What we've done since COVID has started, the EOC came into this space, this is the network of services that we've provided as we provided leadership in this space. This is in addition to what has already existed within the community. It's important to maybe identify here that when there were capacity restrictions due to COVID, and really also another key element, we made the decision very early on to not turn anyone away. Previous to this, depending on the shelter provider, if they were at capacity, folks were turned away and there was a gap in truly capturing the need and supporting folks experiencing homelessness. We have not taken that approach, and because of that, we've seen the need for services continue to increase, and we'll identify that in the next slide. But just to make sure I also touch on this, what you see here in terms of the map of services being provided comes out to, as of today, around 34 contracts. And the February expenditure that we were tracking is roughly around 3 million. And it's important to maybe note with that, that's not a static number. It hasn't always been 3 million every month, but that's kind of presently where the operation is at in terms of being able to maintain the services that you see on the screen here at the moment. Next slide, please. This information here is the average monthly shelter census. This data was previous to COVID, was supplied by Nancy Burke in her role as the homeless coordinator for the municipality. And since then, we have simply added on to that data with our own tracking. You'll see in February that number was 959. As I maybe articulated just a few slides ago, this is the exact opposite of what we would normally expect to see in a traditional mass care emergency shelter response. As the need has increased, we have increased our capacity, and mass care has continued to grow. And it's also maybe important to note here, some of this is because of our decisions to not turn anyone away. Some of this is the robustness of our response. And the other part of this too is we do want to acknowledge that not everyone here in this 959 number is necessarily always been homeless or has been identified as someone experiencing homelessness. Some of this is just purely due to the economic dislocation of COVID itself. So we want to acknowledge that there is an emergency response nature to the services we've been providing. Next slide, please.
Actually, before you go on, I've put myself in the queue.
Oh, please.
Excuse me. The 959 number, you indicate that it may be a variety of individuals. Where is that data coming from? Is that facility reporting? Is that through the Homeless Management Information Service or system? And how does that number compare to the overall capacity in the system between the private providers and what the EOC has stood up?
Thank you, Chair. Great question. That number is self-reported numbers from principally I-teams and then our own daily tracking as well. And the next two slides actually speak specifically to maybe some of those numbers as well. I hope, does that answer your question?
Great. Yeah, I'll see if the next two slides finish answering it. Thank you.
Absolutely. So to speak to the chair's question here, what you see here is a snapshot specifically from yesterday as to what our capacity is around all EOC MOA funded congregate, non-congregate shelters, and then also their daily census. This number here in total is 814. So as of yesterday, the EOC has housed 814 individuals across all shelters. Next slide, please. This graph identifies the capacity of MOA PEH, non-MOA PEH facilities, so shelter providers within the community. We don't have their self-reported numbers, but what we do have here is the identified capacity limits of the various locations. You'll note previous to the response, their capacity was much higher than after COVID, and progressively as we've gone through the disaster, some of these locations, their capacities have shrunk even more. The total capacity here is 222 individuals. Adding that total capacity number with what we housed yesterday, the total number of folks, should everything be full, is 1,036 individuals. The 2020 continuum of care point in time count was 1,058. So from these numbers, I think we can project or insinuate that we have almost captured the breadth of what the population of individuals experiencing homelessness is within our community. And it sets the stage for us to have some good conversation, which we'll introduce David Parker for, around how we continue to serve this population of individuals. Chair, just want to be sure, has this answered your question, or do you have more questions?
Thank you. We have a question from Mr. Weddleton, and then if you could address after his question or before, the last two boxes where it says COVID-19 and COVID revised, are those 2021 capacity numbers? So is that from March to August 2021 or August 2020? I guess I'm a little bit confused. So you could just put the, oh, I just got it. I'm sorry. So the box is COVID-19 March to August 2020, and then September 2020 to April 2021. Is that the accurate way to read that?
Yes, Chair, correct.
So do we have the numbers for the predictive numbers for the remainder of 2021, or is it on a consistent rolling basis where we're just getting updates?
Good question. We expect that number to go down, but at the moment it is day by day.
Okay, thank you. Mr. Weddleton.
Thanks. So a little question on Covenant House. On the slide you're on now shows that capacity is 60 and they're at 60. The previous one showed a different number and they had 3 people there. Covenant House, yeah, capacity 20, 3 people. What's going on there?
Assemblymember Watson, thank you so much. Yeah, so in this slide here with Covenant House, it's very interesting. They have a capacity within their own facility of 40 people. And then through a partnership, we've identified the use of their gym as an emergency congregate shelter for our use. So the 60 number that you see in their capacity includes the 20 that are available for our use.
Okay, thanks. And then on the previous one, you have a couple that appear to be over capacity.
Yeah,
Site 1, substantially over capacity. I mean, what's the story there?
Yeah, so in a lot of these locations, depending on the site and these non-congregate locations are almost exclusively hotels, and depending on the room configuration, their own policies around guests or the number of guests within a single room, a lot of the overcapacity is simply couples that are being housed in one room.
Okay. Oh, gotcha. So capacity in that would be for the non-congregate is number of rooms and not number of people.
Thank you, Assemblymember Weldon. Yes, exactly. Okay. So the capacity here is simply the total number of rooms we have. The daily census, the actual number of individuals being housed within that facility. The family shelters may be a good example of this too. The suites that we've contracted for those use are much bigger, can support a much larger group, and are better used for that. Are better used for that purpose. But that's why you see that the discrepancy there as well.
All right, thank you.
Thank you. We have a note in the chat from EOC Mass Care Technician. I believe Site 1 is a family shelter situation. Please continue.
Okay. Next slide, please. Oh, sorry about one more. Okay. So at this point, I just want to make sure if there's any more questions just about the current status of the mass care response and our locations. Happy to answer those questions. Otherwise, would like to turn this over to my colleague, Dr. Parker, to talk through the transition specific.
Great. Please go ahead. I don't see any other questions right now.
Okay. Dr. David Parker has a PhD in epidemiology and over 20 years experience in both infectious diseases and homelessness. He's currently the EOC Mass Care Technical Specialist and is also a professor of public health at the University of Alaska Anchorage College of Health. David's helped develop over 1,000 units of supportive housing run shelters, overseeing data systems for persons experiencing homelessness as well. So at this point, I want to turn it over to Dr. Parker to talk us through the EOC's efforts around transition.
Before you start, Dr. Parker, I have been remiss in noting for about, I think, the last 5 to 10 minutes, member Crystal Kennedy has joined us here in the room. Thank you.
Hi, good morning. I would first like to confirm that everyone can hear me okay?
Yes, loud and clear.
Great. Sometimes I forget to press a button and, I talk for 5 minutes. So today what I'm hopefully going to provide information on are opportunities and resources that I believe we have moving forward to address homelessness in the Anchorage area. One of the things to bring up, I think, is that systems are great and you can have a perfectly designed system, but if the implementation of that system is not efficient and the units or the parts of that system are not accountable, or people don't understand to use them, or they're not user friendly, even the best designed system will not be so successful. One untapped resource that I think we have in the homeless services community in Anchorage is the use of the Homeless Management Information System, which is a software that has mandated the use by HUD. And to clear up, there's been a bit of confusion around HMIS. HMIS, if you think about it, is kind of like a make of a car. There are many different makes of cars, but they're all maybe cars or automobiles. So for instance, with an HMIS, it's just a general catch term, and there are many different software systems that are available within this. However, getting back to sort of the point of this slide, Housing and Urban Development does mandate the use of HMIS system for data collection to capture information on program services and outcomes. And these data get reported to Housing and Urban Development, and each year HUD produces the annual homeless assessment report that is submitted to Congress. And it is from these data through HMIS that we are able to get funding through several different mechanisms, including formula-based block grants, as well as money that is through the continuum of care system. Also, there are other opportunities for funding that are oftentimes made available to communities on a competitive basis. One example of this could be an area, for instance, like what's called the Special Projects of National Significance, which is a joint operation most often between the U.S. Centers for Disease Control and Department of Health and Human Services, Health Resources and Services Administration. Oftentimes, those programs or projects specifically focus on persons with HIV. However, there are another number of competitive funding opportunities. And so the reason I bring all of this up is having excellent data underlies the ability not only to provide services, to know to whom you are providing services, but also to be able to explain the situation and measure changes over time. And this is why HMIS data on the national level and oftentimes at the state and local level are used for policy and program planning. And as I've already mentioned, the data are used commonly to support applications for multiple funding sources. Next slide, please. This just is a graphical representation of a solid working person or homeless care system or homeless services structure. This is a graphic from the Santa Barbara Continuum of Care, and it's very similar to a number of graphical representations of fully functioning care systems across the country, where you have a person, you sort of have this funneled into a system process, which is here on the left side in red, where a person is having some type of a housing crisis, whether they be unsheltered or at the risk of homelessness. Those people would then contact or be funneled toward the coordinated entry and assessment program. The major focus of this coordinated entry and assessment program is diversion, meaning diversion from the homeless care system, such that a person who is at risk of homelessness could be provided recommendations or referrals to a service organization that could provide homelessness prevention services or potentially housing prevention or housing problem solving services that would be able to clear the path for them to remain in housing. The first step is to try to keep people who are in housing but are at increased risk of losing the housing in housing. The second group of people would be unsheltered. Oftentimes, the unsheltered population cannot be diverted. These are generally the people for whom the homeless system is designed. They then go through an identification or an assessment where you look at the housing barriers. And then these people are placed on, the people who have been assessed are placed on a prioritization list. And there's been, over the past several years nationally, a major shift in the paradigm of prioritization lists. It used to simply, well, maybe not simply, but it used to be based on a couple of different screening tools, and the score which a person received would sort of like a triage situation. They would maybe be placed at the top of the list based on this score. However, research and practice over the last few years has borne out the fact that this tool is not effective, especially for persons experiencing serious and persistent mental illness, as they may not correctly or may not at all answer any of the questions. But anyway, there is a prioritization list, and people are routed to the housing service that is most closely aligned with their needs, whether that be rapid rehousing for people who maybe are experiencing homelessness for the first time, or people who just need help getting back into housing, all the way to permanent supportive housing, which is designed more specifically for people who have a disabling condition or who have a situation where they need assistance. All of this is to say that when you have a fully functioning coordinated entry system, as has been mandated by HUD, I believe since 2014 or 2015, you're much more able to respond to the situation. Next slide, please. Next slide. Hello?
Mr. Dole, are you with us? Could you, there we go. Thank you.
There we go. Sorry, for a minute, I was wondering if anybody could hear me. So one of the resources that we are deploying in an attempt to resolve a lot of the issues that exist currently in Anchorage with the homeless population is an approach called intensive housing case management. Now, some people may be familiar with a Medicaid reimbursable term, intensive case management. Intensive housing case management is a bit different than that. There is no reliance on clinical care or clinical services through intensive housing case management. The idea here is that a case manager will work with a person who is homeless, determine with that person what their needs are, the problems that they are experiencing, and the barriers, and they develop a individualized service plan. Part of the service plan is that each of these should be aligned with an objective that can be measurable over time to document a person's progress, but more so than that, to help a person understand really what the barriers are and how they may be able to be more successful in obtaining and maintaining housing. The RFP, we have a request for proposals out right now, which we're asking for 12 full-time equivalent intensive housing case managers. The expectation is that each of these case managers will have a caseload of approximately 25 persons. This does not mean that each case manager will have 25 high needs persons. Usually what happens is you get a person into care, they begin to stabilize, their needs start to decrease once they are placed in housing. This would be using a housing first approach. The person is placed in housing, they stabilize, and then you work with them in an ongoing fashion until they can be connected with mainstream services or other care systems that could more align with their needs. I see that there is a question.
Oh, yes, I didn't mean to interrupt your slide. So I placed myself in the queue. If you could address where or how the approximately 300 people, that's 25 persons per 12 full-time employees, will be identified to receive intensive housing case management.
Sure, I can go ahead and address that right now. Depending on when this contract is picked up and started, through the congregate and non-congregate shelters. Right now, specifically, we have more medically fragile people in the non-congregate shelters. And we, the EOC, are going through and identifying or have already identified a number of the needs of the people as far as housing, medical care, and other services that are needed. We're trying to link them with those systems of care now, but our idea is that we will have a number of people already prepped and ready to go once the case management program hits the street.
Thank you. Mr. Weddleton also has a question. Please go ahead.
Yeah, thank you. So we could get more case managers out there, but are there houses or homes to put these people in? And my understanding now is we have outreach people going out and talking to people on the street and working with them and getting them on a list for housing, but there's no housing for them. So it's sort of an illusion. Is that, please tell me that's wrong.
That's wrong.
Thank you.
I'm kidding. Well, no, and I'm really not. So we have been working to identify the housing stock that's available in Anchorage. And you're right, there are outreach workers out there now. There are case managers out there now. And what's happening is that people are being placed on the prioritization list. And for some reason, there does not seem to be a connection between people who have an intake or an assessment into case management or to outreach services now and actual linkage to housing. It doesn't mean that there's not housing available. And one of the focuses or foci of the intensive housing case management is to coordinate with mainstream services. So there are services or housing assistance programs available for people that are, for instance, elderly persons, people over a certain age. There are subsidized units that are available. I don't mean to make this sound easy peasy, but I think that there are a lot of what I call mainstream benefits or other housing options outside of the continuum of care that have not been explored in Anchorage. And I think that's one of the reasons why we have so many people that are not in housing. Does that answer your question?
Well, I guess it starts to, and maybe it would be a whole nother meeting to find out why we've not done this before, but.
Well, I think that intensive housing case management is a completely different approach than what has been taken in Anchorage before. So the idea or the outcomes and I've only been here for 10 months, so I'm speaking a lot with an outsider perspective, but also as a person who has run homeless programs for 20 years. This is a major paradigm shift for many places across the country. Many places still look at the number of people placed in housing as the marker of success, not necessarily the number of people who maintain housing. Also, we have the fact that case management here, as I understand it, for most case management, the clients who are placed in housing do not necessarily have case managers who continue to work with them for an extended process. Also, I have identified a couple of situations in Anchorage where an organization would be contracted to provide case management services, yet they had no access or money for housing. And then when, for instance, the case management contract ends, then housing funding is available. So there's not been an opportunity to really coordinate these services, because if you think about the fact that if you fund case management for 6 months, but there's no housing, have funding to help people get into housing, and then the case management contract ends and then you introduce funding for housing, you have nobody, to help the people get into housing. Maybe I'm going way far afield, but does that more clearly answer your question?
Yeah, it's shocking to hear that happens, that we'd have such a disconnect. And we've been working on this so hard for so many years. So it's, but I guess we keep working on it. Thank you.
Yeah, so Anchorage is not alone in this. I do want to say that, but I also do want to say that for the time and period that I have been working in this field, I have never seen a sicker population than the homeless people of Anchorage. I think that in any other areas or in other areas where I have been, we were able to be more successful, especially among people with physical and other types of disabilities, to get them into what I'm labeling here as mainstream services. But the focus of one of the areas of emphasis, I guess I should say, for these intensive housing case managers is SOAR certification. I know we're not supposed to use acronyms, and I apologize, but SOAR certification basically is an online certification process by which a case manager can be enrolled essentially in a program where they are able to expedite access to Social Security disability or Social Security supplemental income and food stamp benefits, which are SNAP enrollment for people. So as an example, I just moved here from New York. New York, it's about 24 to 36 months for a person to have a disability application approved. For a person who's working with a SOAR certified case manager, that's down to around 12 months or less. Prior to that, in the other states where I was, West Virginia and South Carolina, we also saw a 50% or more reduction in the time period waiting. A lot of that is just the fact that the case managers are better trained, but in addition to that, also when you have a SOAR certified case manager, they have the ability to submit applications through an expedited process. So with these intensive housing case managers, again, following the clients into housing, assisting with the transition, but also remaining with the clients is going to be crucial. Next slide, please. Cost savings implications. I've learned in my life that generally people care about two things, people or money, and sometimes they care about both. The great thing about Housing First and intensive housing case management approach is that it addresses both. There's over 20 years of published research that consistently shows significant cost savings in communities where intensive housing case management is used in conjunction with the Housing First model. This gets back to my statement when I was speaking specifically of HMIS, where you can have a great system, but if the implementation is not successful, you will not benefit from that system. That's the same with intensive housing case management. There are literally, and I'm using that in the literal sense, literally, hundreds of peer-reviewed publications that demonstrate cost savings. This is all across the gamut, from decreased emergency department visits and inpatient stays, reduced days of inpatient stays, drug overdoses, fewer incarcerations, less police involvement, and increase to behavioral and physical health care is a major boon for people who are involved in Housing First intensive housing case management program. One of the key measures for success is having outcomes developed and program fidelity measures in place so that you can determine what the clients need and is your program matching those needs, and what are the outcomes in which the clients are being successful. And when your landscape changes as far as opportunities available through mainstream benefits, your program should also change to be able to take advantage of that as much as possible. And I have a list of 55 peer-reviewed published references. If anyone is curious or would like to get those, I've included some down at the bottom. The 55 list, or the list of 55 I have, are, I believe, published in the last 6 years. And these do not all give glowing reviews. It's not like I did a literature review and said, here are 55 references that support my position. Some of them show that there is no benefit, but again, in most of the strengths and weaknesses in those publications, they bring out the fact that there were local implementation problems. Next slide, please. So the shelter transition plan, what do we know about how or what we are going to do with the people who are currently in the shelters? I am very happy to report that I'm working with a great group of people, including representatives from the Anchorage Health Department, the Anchorage Coalition to End Homelessness, the United Way, Housing and Urban Development, and the Alaska Governor's Office, among others. And this process is being facilitated by Agnew Beck. We came up with a transition plan that focuses on looking at shelter inflow, meaning clients or guests coming into the shelter, outflow, as well as data collection. We identified a scope of work which includes 4 tasks. These tasks are to essentially document the mass care shelter operations. This includes location capacity, the services provided, the data entry, and all of the providers that are engaged at each location. The second task was to come up with a very brief report on the current EOC operations as far as shelters. Task 3 is developing a coordinated shelter stabilization or transition plan from the EOC. And the last task, which we're going to be working on, I believe, starting next week, is creating an action plan for continued shelter operations post EOC. So we have completed the first 3 tasks of this with a target date for task 4 of April 30th. Next slide, please. So what do we know right now as far as the mass care shelter transition plan? We have, and you're going to see a different number here than what was reported previously, and I will explain this. 733, what I have labeled EOC beds with an average nightly census of 702. The reason this number is different is this does not include the 100 and something quarantine and isolation beds. This also does not include the warming tents as well. This number does not include the Covenant House 20 beds essentially that we have contracted for adolescents and young adults. And this also does not include families or domestic violence, people in domestic violence shelters. This is unaccompanied adults. And you may wonder why I removed all of those people. It is because generally those groups are people who have access to additional resources. So by focusing on unaccompanied adults, we will be able to more specifically address what I believe most people see as visible homelessness. So to transition all EOC shelter guests right now, the only tool that we have in our arsenal is the Intensive Housing Case Management Plan, which, as Assembly Person Zalatel mentioned, would be able to work with 300 people at any one point in time. I believe the RFP for this closes on the 14th, and the first review is shortly thereafter. That's April 14th. So depending on when this program hits the street, we may be talking June or July before the case management team is really operational. So what we're going to do is also try to get people housed through existing opportunities, and that's really a nebulous statement because right now the non-governmental organization, the NGO shelters in town are at their new capacity as mandated by, well, not mandated, but highly strongly recommended by the Centers for Disease Control. They're at capacity. So, you know, the non-congregate private shelters, the non-congregate shelters that the EOC operates, you know, when these things all wind down, right now, we don't have a huge arsenal of tools to address these needs, but getting people linked to treatment programs, care homes, skilled nursing facilities, any type of community housing are all avenues that we are exploring. Is there a question?
Yes, I put myself in the queue. I want to, for 2 reasons. One, a bit of a time check. We need to wrap up in about 8 minutes, so we have time for audience participation. As well as I just wanted to flag on the slide, I have a bit of a concern, and I always preface anything with math to say, check my math. But if we are able to house 300 people through intensive housing case management, we recognize that our non-governmental shelters or our private shelters are at capacity. I still see quite a deficit moving through the summer, even for EOC beds. At over 400 individuals, and I guess that's concerning. I hope that as we see this task 4 plan come forward, we see the plan for the remaining individuals, recognizing that as of right now there is no private shelter capacity to take anyone in, and we would really, I mean, it's my preference that we don't move people from shelter to shelter, but shelter to housing or somewhere much more permanent. So I wanted to share that thought and flag that as something I hope we can see here in the future. Thanks.
I would like to see that as well, but unfortunately right now there is no resource that we have available in order to put that into place. You know, the 300 people that we have listed as transitioning through intensive housing case management, again, if the intensive housing case management program starts in June, I don't know how many people we would actually be able to get into housing. And while task 4, we are going to work, and our very good friend and colleague at Housing and Urban Development is putting together a meeting of organizations who will be receiving significant amount of funding. You know, that is an opportunity, but right now I don't foresee, without something changing from the municipality's perspective as far as housing, I don't, you know, I'm concerned there will be more than 400 people who will have no place to go. And on your time check, I think next slide, because I think we're almost finished. Yep, key considerations for shelters. I'm not going to read this to you guys, especially in the interest of time. But if we're able to increase residential substance abuse treatment for all persons, not specifically only homeless people, but increase coordination with disability services for housing and senior services, I think we will be able to help people move into other housing structures. And just in the interest of time, I will just go ahead and say next slide. And I believe this is Bob.
Mr. Dole, would you like to wrap us up here with these last slides? And if you happen to be speaking, you're on mute.
Sorry, I was fighting multiple screens there. So I would wrap up quickly just to note that we still have some headwinds with our response there that we know we have to deal with. And you can see those before you. The big thing is we don't know what COVID's going to do, and we don't know what the time and duration and resources are to deal with that. We also don't understand at this point fully the response of the public in terms of overcoming vaccine hesitancy and maintaining protective measures going forward. That completes our presentation, barring any further questions from you.
Great, thank you. We do have a few more questions. Ms. LaFrance. Thank you, Madam Chair. And first off, thank you to the presenters, Dr. Parker, Mr. Transberg, Mr. Dole. Very much appreciate this information. And also wanted to note that the presentation is available online on the committee's webpage. Thank you, Ms. Leppy, for posting that. So just a couple of questions and maybe more clarifications, actually. The first one, Mr. Dole, goes back to the, sorry, one second here. The AEOC, in terms of the relationship with a local emergency declaration. And I understand just from looking at the time frame, the AEOC was actually activated before the Muni's declaration. And so could you address the relationship between the local declaration? I understand that it's an issue of personnel resources for one, but is there anything else that pertains there to it? Thanks.
Through the chair, Assembly Member, or I guess Co-Chair, Assembly Member LaFrance, looking at the timeline, you do not need a emergency declaration in order to stand up the Emergency Operations Center. The Emergency Operations Center is stood up when the complexity exceeds what existing authorities can do to address the mission, the complexities beyond it. The authorities relied upon by the Emergency Operations Center to continue optimizing the response, if you will, are twofold in there. First, the expedited procurement authority, so we can be agile and flexible in responding to the disaster without pre-purchasing excess capacity that we don't need, may not need, so we just can get it when we need it, if you will. The second area is that ability to cross-align resources across the municipality, that fourth authority, so your building official can step in at the incident commander level if when there's a need to rotate out.
Thank you, appreciate that, Mr. Dole. And then just really quick, Madam Chair, one other question, or maybe more of a comment about resources, which Mr. Dole, you identified long-term staffing needs as a headwind. And in terms of the health department, which clearly will be absorbing these functions as we transition away from the emergency. Sorry, I'm trying to read my notes here. We can expect to have a second transition, one out of this emergency situation, and then a second away from FEMA funds, assuming that the federal emergency will continue through the year, perhaps beyond.
I mean, is that a correct statement as you see it, as a second transition?
Yes, through the chair, or yes, Assemblymember LaFrance. I would clarify though, I see the first transition as internal to the response. AHD and OEM will continue prosecuting the disaster response. We're just at a point where the complexity does not warrant standing up the Emergency Operations Center. So at the end of the disaster, there is a new transition back to what the peacetime or non-disaster response organization needs to look like and be resourced to do.
Okay, got it. Thank you. Thank you, Madam Chair. Great, thank you. Thank you to the Emergency Operations Center and our presenters today. We're number 4 on our agenda is committee, legislative, and budget priorities. Unless somebody has something they would like to raise, we didn't have any particular items except for Member LaFrance. Please go ahead.
Thank you, Madam Chair. I just wanted to call attention to a resolution AR 2020-65 that the Assembly passed last February, and it was concerning Tobacco 21. We had encouraged the state to raise the minimum age, which has been done at the federal level, but we also had asked the state legislature and governor to remove the criminal penalty for underage possession. And I just wanted to flag this as perhaps an item that the committee could take up in a future meeting, and we may want to have another resolution to bring that to the forefront of the new legislature. Thank you, Madam Chair.
Thank you, Member LaFrance. So now we'll turn to audience participation. We will start with in-person participation, then go to the Teams Q&A and the telephone. It looks like we have someone here to participate. Welcome, Mr. Haberman.
Are you going to set a clock, or do I?
I'm sorry, I have my clock here, which is what I usually use for committee, and I
Okay.
have the alarm on, so it will go off at 3 minutes. Please go ahead.
My name is Eugene Carl Haberman. What I'm going to talk about is an item that you should all be aware of. As I've stated before, whatever Anchorage's efforts in dealing with COVID, it's a wild, wild west in the valley. Now, this is the first time since your last meeting that I was able to report to the Assembly and this committee on the outrageous behavior of a town hall legislative meeting held in the Valley in Menard Center. I was there. There were hundreds of people in the room. No member of the legislature was wearing a face covering. It was a small meeting room. And a couple members of the press were wearing and so forth. But even the governor's representative for the Valley was not wearing face covering, including the mayors of Palmer and Wasilla were not wearing face covering. Now, it takes a lot for me not to attend a meeting. But after taking a few photos, I walked out because this was an unsafe situation. And I'd like to remind you, too, we've been hearing reports of number of members of the legislature having COVID. And this happened just about a week ago last Saturday, this situation. So they went back there to the legislature and in their outrageous behavior went back there. And my guess was it's most likely they are going to be the key factor to with other members of the legislature getting infected by COVID. This is what's going on. Now, the news, I saw a news scenario with the elections yesterday, and couldn't help but notice, although there's mandates for social distancing and masks, but if you look at the newscast, the election headquarters, so forth, you saw where were the masks. Some of the candidates were respectful and responsible. Others were clearly not. What we have in Anchorage, the Valley, across the state is a situation of it's safe now. No need to wear masks. Also, I already been tested. I already had a vaccine. Don't need to wear a mask. This is not the time to go away from wearing masks. And note this, we do not know, even those who are getting a vaccine, how long it's going to be effective, if at all. It could be 6 months, it could be a year, whatever. And the end result is this is not the time to play in this story. And then also want to say is the Menard Center, respectfully, has been a key place for the sports thing. It was that same building where I walked in with that town hall meeting where you got the athletes from Anchorage going over there. And as a result, as I said, you require more responsible behavior here. They go out in the valley and they get COVID. Thank you very much. My time's up.
Thank you, Mr. Haberman. Do we have anyone through the Q&A or on the telephone who would like to provide a comment? We have time for probably one more individual.
There's no Q&A, but I can start through the telephone list.
That would be fantastic. Thank you.
Caller ending in 0522, you are now unmuted if you would like to speak.
No, thank you. I'm fine.
Caller ending in 8640, you are unmuted if you would like to speak.
No, thank you.
Caller ending in 1793, you are unmuted if you would like to speak.
Actually, Mrs. Zaratel, that's me, Dean Gates. No, I don't have anything to add.
Okay, thank you. And caller ending in 4421, you are unmuted if you would like to speak.
Yes, can you hear me?
Yes, go ahead.
Thank you. This is Donna Avey, and I represent a volunteer human service organization. Why I'm concerned is that it's obvious in the action planning stage, which will be the rest of this month, that you're addressing some unresolved issues over housing. And I was wondering about the community council role in, they work with planning and zoning, and can the assembly address this, the gap in housing through asking for creative thinking and problem solving with community councils and addressing more grassroots volunteer participation in the process that's happening right now? I don't know who this question goes to, but I would bring that to our committee to take back to the assembly and the community councils, because real estate, you know, the housing issue is complex, involving real estate and private enterprise and public enterprise. And I trust all the entities that are working so far are doing excellent. And it sounds like my time's up.
Thank you so much for your participation, and I will follow up with Co-Chair LaFrance about this, as well as Vice Chair Constant on the Committee on Housing and Homelessness. This is a fantastic idea, and we'll see what we can do. With that, we are adjourned at 11:02. Thank you, everyone, for your participation.